Then, ladies and gentlemen, we have periapical abscess. So with periapical abscess, that's basically a localized destruction of tissues, especially periapically, and an accumulation of the exudate or the pus, if I can put it that way, in that periapical region. So when a patient comes in, they may present with moderate to severe discomfort and or swelling. So that's normally an indication of periapical abscess. So this will basically be the destruction of tissue, as your slide says, like I mentioned, tissue, and then exudate formation periapically, and then exudate will be present, so that would be the abscess or the pus that we found. So basically we're going to have like lots of pressure in that pulp. Okay, so to remove that, the pulp or the pressure must be released. We release the pressure by one, opening the pulpal chamber. So we're going to open up the pulpal chamber, and then from there we need to remove the necrotic pulp. Okay, so and then after that, basically root canal therapy then needs to be done to correct this particular disease manifestation. Yes, so with endodontic diagnosis, we need to take medical as well as a dental history, as with any other patient, okay? So the medical history will just help guide us in terms of any medications or any medical history that can help in giving us a complete diagnosis of the tooth. And then from there, dental history, we'll get into that into much more detail, but obviously having dental history, knowing the previous treatments or the history of the patient can help paint a picture of possible causes that may lead us to our ultimate diagnosis. And then from there, there's clinical examination. So as with everyone else, clinical examinations will be both extraoral as well as intraoral. So extraorally, we're looking for signs of any asymmetry, any discoloration or swelling, any external fistulas, especially around the angle of the mandible, but external fistulas that could be indicative of something intraorally. And then with the intraoral aspect, obviously you'll be checking all the soft tissue. We'll then be doing a multitude of tests that we will discuss later on, just to diagnose the tooth that the patient brought in today. We'll be looking for fractures, we'll be looking for caries, we'll be looking for discoloration, we will be palpating the tooth, checking for any swelling, checking for any internal fistulas, if I can put it that way, intraoral fistulas, any abscess or swelling, even reddening in the particular area. So those are a couple of things that we'll be looking for intraorally. And then from there, referring to a dentist note, sometimes a patient will be brought in to you from another practice, or sometimes even going through your own notes if the patient is a client of the practice, just to get a rough idea of possibly what went wrong, or help give us signs and symptoms that lead to our ultimate diagnosis of the tooth. It's very important, ladies and gentlemen, that as we're taking the history, to also, again, I cannot emphasize this enough, talk to your patient. So we want to give the patient a platform to actually describe what is happening in their words. Okay, so we will be asking the patient, when did the pain start? Like, what does the pain or what does the tooth react to? Is it cold or heat sensitive? How long does the pain go on for? What is it sensitive to? Is it painful when you touch it? Like, we ask all of those questions so we can actually exclude some symptoms or even diseases from our diagnosis list before we actually come to a diagnosis. This is very important because a lot of the diseases with endodontics, they're quite similar and they're normally treated the same. But obviously, if you diagnose a patient properly, you will then give the proper treatment. So diagnosis is very, 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 very important with endodontic patients. Né? Okay, so medical history, we want to review and clarify the medical history. Sometimes with the medical history, it will provide information that will lead us to a specific question or diagnosis relating to this particular tooth. So we want to know of the patient's medical conditions as well as the medication that he or she may be on. And then with the dental history, we review past dental experiences, what they've done at other practices, or even with our own clinical notes, and then what are the current concerns of the patient relating to that particular tooth. We'll then do a subjective examination, like I mentioned before, talking to the patient, the type of pain, is the tooth sensitive to heat or cold, and then how long obviously does the pain last for. Okay, so with the clinical examination, like I mentioned before, we check oral, extraoral tissues, asymmetry, swelling, redness, as well as fistulas. And then with the intraoral examination, so the tissues are evaluated as well as palpated. So for caries, discoloration, and fractures, but we've done that already, né? Yeah. Okay, so now we're going to discuss some clinical testing procedures that we can do for endodontic patients. So firstly, it is radiographs. Radiographs are very important. They are non-negotiable. And with radiographs, ladies and gentlemen, you need to make sure that we get the periapical area of a tooth, not just the tooth itself. We must get that periapical area. You remember when we were discussing periapical abscesses and irreversible pulpitis, we talked about the destruction of the lamina dura as well as the destruction of the periapical tissue that is underneath the tooth. So if we do not take an appropriate x-ray, we will not see those areas. So it is very important. Normally with the root canal, we take about, from start to finish, we take about 5 x-rays. So we'll continually take x-rays to check our progress when we are doing the said treatment. Okay, so your slide basically talks about the radiolucent area on an x-ray. Basically indicates bone involvement. So I think that's basically self-explanatory. Yeah? So the second test would then be palpation. So palpation is basically a dentist coming in, obviously with a glove, and just palpating the soft tissue that is on the periapical area of a tooth. Okay, so we're not just going to palpate that tooth, we're going to palpate even the adjacent teeth. Okay, sometimes in palpating that tooth or those teeth, you will find pus-filled areas, so that will also be helping with your diagnosis of that particular tooth. And then from there we have percussion. So with percussion, ladies and gentlemen, you use the other side of your mirror, and then you isolate the tooth, you dry out the tooth, and then you will percuss 2 teeth. So it will be your control tooth as well as the affected tooth. So if, for example, your patient presents with a painful 1/6, you're going to first start by percussing the 2/6, which is your control tooth, and then comparing the patient's reaction when you actually percuss tooth 1/6, which is the tooth that they actually came in for. Okay, so you're going to percuss your control tooth. Once you get to your affected tooth, if the patient feels like mild or moderate pain, let's say you percuss and they're like, so that would normally be indicative of like periodontal inflammation. Okay, but if you percuss, let's say 2/6, and then you come to the 1/6 and they chop like a sharp pain, okay, that's normally indicative of periapical inflammation. So that would also help you guys come to a diagnosis and then decide on a treatment plan. Yeah? So that is basically how you percuss a tooth in private practice. And then from there, okay, then we check for mobility. So with mobility, you'll be the dentist will be holding the tooth on one side and then using an instrument like your mouth mirror on the other side, and then you check how mobile that tooth is. If a tooth has 2 to 3 millimeters of mobility, a root canal treatment is not indicated, ladies and gentlemen, because the tooth fundamentally does not have enough supporting tissue. Therefore, it will not last in the oral cavity. So it's better off to extract a tooth that has so much mobility. And then from there we have our cold test. So our cold test can be done with either dry ice, ethyl chloride, as well as normal ice. Normal ice is normally fabricated with like sterilized water. Okay, so basically when you're doing a cold test, you're going to dry the area and then you're going to put like a cotton roll, né? And then from there you're going to take the ice and actually put it on the facial surface of a tooth. This test, the cold test, is mainly done or more effective on anterior teeth. Okay, so in a normal tooth, within a few seconds the patient will feel some form of pain or a sensitivity to the ice that you put on the facial surface. But then with teeth where like that have irreversible pulpitis, the moment you put that ice on, it takes quite a while for the pain to actually be felt by the patient. Okay, so if the pain is long lasting after you've placed the ice, it is normally indicative of either necrotic pulp or irreversible pulpitis. And then the other option would then also be a heat test, but they're normally done in conjunction with one another. So with a heat test, we will be taking gutta percha. So gutta percha, ladies and gentlemen, it is the material that we place into a tooth after we have cleaned the tooth out and basically done the root canal therapy. So we are basically completing or filling that pulpal area with gutta percha material. So in this instance with heat test, you basically make a little ball with your gutta percha material. You will then isolate the tooth again, and then on this facial surface again, put that heated gutta percha ball onto the facial surface of a tooth. Okay, normally if the thermal sensitivity or the gutta percha, that pain is maybe dull or long lasting, that would then again be indicative of irreversible pulpitis. Normally, like we said, ladies and gentlemen, with necrotic pulps that have undergone severe damage, these tests like don't work. So they won't be like either cold sensitive or even heat sensitive, or the heat sensitivity will last for a long time, like longer than 20 seconds. So that's when you'll just know what the patient basically suffers from. Okay, then other tests include pulpal testing. So pulpal testing or a pulpal test just helps indicate whether a tooth is vital or not. The problem with this test is that it normally gives false readings, né? So it's not good enough to do it alone. You have to do it in conjunction with other tests to actually come to a conclusion. And then from there we have trans-illumination tests. Okay, so trans-illumination tests, they make use of a strong fiber optic light that transmits light from the crown of the tooth. Okay, then this light produces shadows that normally help indicate vertical fractures. Okay, so that's with trans-illumination tests. And then from there we have selective anesthesia. So this is normally done in patients where they're not quite sure which tooth is the source of their pain. Okay, so in such instances, the patient cannot identify the tooth or the arc that is causing all of these problems, and then thereafter, basically, as the dentist, we basically then inject the patient. Okay, so one area of the patient's mouth is selected and then injected. Okay, so if this anesthesia alleviates discomfort in that area, we know that we've identified essentially the problematic quadrant. Okay, and then usually selective anesthesia is normally done on maxillary teeth, beginning in the most suspicious anterior area and then progressing to the posterior area, and then from there we go on to caries removal. So sometimes a patient may not have symptoms, but we can see on the x-ray that maybe the caries are deep. Okay, or maybe there are even issues periapically. So sometimes you also find that even the other tests that we've conducted are also positive. In such an instance, we'll obviously anesthetize the identified tooth, and then from there we're going to remove the caries. By removing the caries, we can then decide whether the tooth is irreversible or reversible in terms of the pulpitis that we've identified on that said tooth. Okay, then from there, depending on what we found, we can either do root canal therapy or place a temporary restoration or a permanent restoration, but with sedative material underneath. Yeah, so that's normally what takes place with caries removal. And then the following slide has a dental check for you guys that asks what is an advanced stage of periapical infection that spreads into the bone. So that is known as osteomyelitis. So that's just a nice quick dental check for you guys, but we've basically covered the gist of the dental conditions that you guys need to be aware of. Hey ladies and gentlemen, we are going to basically do endodontic instruments now. These are very, very, very important for you guys to know. Now we're going to start off with bobbed brooches. So bobbed brooches basically are a thin metal with little tiny projections on them. Okay, so they are long and tapered, but they allow for entry into the canal, smooth entry into the canal, but as you pull them out, they basically catch tissue and remove it out of the pulpal chamber. So that's basically their importance. So they remove soft tissue from the canal, as I said. So smooth entry, but on their way out, they catch and retract tissue as you remove it from the canal. They are designed to cut tissue when pulled from the canal. They have also different sizes so that they allow for smooth entry into the canal, but not in such a way that they actually bind to the canal. So it's the dentist's obligation sort of to make sure that they select the right brooch at the right time. So they have various sizes, starting from extra fine all the way up to coarse, and then they are also having color-coded handles. So that's basically what bobbed brooches are. We then have files, ladies and gentlemen. So normally we use files to gain entry into the canal, as well as to remove tissue from the canal, and then as well widen and shape the canal as we are basically making use of them. So files basically enlarge and smoothen canals. They remove necrotic tissue, as I had mentioned before, as well as then help shaping the canal. Okay, so then files have different sizes that are increasing in diameter. Okay, they also are like long and tapered and thin, so that they allow entry into the canal but not binding to the canal, but you obviously have to use them in their increasing size or diameter, for lack of a better word. And then from there, they also make use of a color-coded system. So this color-coded system is standardized across the world. So different files will have different colors. For example, like a size 15 file will be white, and a size 20 file will be red, and whatever. So those standardized color systems, or the files in the standardized color system for endodontic files, are known as K files. Okay, so those are the ones that we use to widen, to shape, and to remove pulpal tissue from our pulp chambers. So there are K type files, or as well as headstrom files, but I just explained that the K files are the ones that are increasing with the standardized colors. They are long, thin, and tapered. yeah, and then you use them with the increasing size up until you get to the diameter that you're looking for, depending on the tooth that you are working on. And then we then have headstrong files. So headstrong files do not work as K files. You know, K files, you use them like in a rotary motion in and out of the pulpal chamber, whereas headstrong files, they have like a cone shape, né? So because of their pine cone shape, you can't actually use them in a rotary motion because they can actually bind to the canal, get stuck in there, break in there, or actually even cause fractures of the tooth, okay? So headstrong files are basically used more in a pull and push motion, okay? So especially like with fractured anterior teeth or with apexogenesis roots, where the roots are basically not fully developed. Okay, ladies and gentlemen, and then from then on we have flexi files. So flex files are either made out of stainless steel or nickel titanium. So these files are basically used in teeth that are narrow or very curved, né? And then they basically have the three main characteristics or properties that we are looking for, which is flexibility, strength, as well as sharpness. They too also come in various sizes, so normally in a 21 millimeter length or a 25 millimeter length. So with your more curved and your more narrow pulpal chambers, that's when then we will be making use of flex files. We then have reamers. So reamers are basically used to enlarge our pulpal canals, né? They also basically have long twisting shanks similar to our K files, but their projections are more widely spaced, né? So the cutting action that we get from reamers is actually not on their way into the canal, but actually as you release them out of that canal, né? They also make use of a color-coded system, but they aren't really as popular or as commonly used versus the K files that we just discussed earlier on.